Thank you for joining us today. Today we're going to be talking about the CHR workforce assessment, and I will be your moderator. Next slide, please. So here are some keys for a successful webinar. All of the participants are currently muted. We are recording this, and it will be made available on our website. There will be a Q&A session at the end of the presentation. There are two ways that you can participate in the Q&A. You can click on the chat and submit a question. You can also click the participants and use, click the participants and you can use your hand icon, which I'll show you at the end of the presentation. And there will also be a brief evaluation that will be sent to you all. Next slide, please. So again, my name is Corey Hemstreet. I'm the Health Program Manager for the Arizona Advisory Council on Indian Healthcare. I will be your moderator today, and I just want to introduce our three presenters. We have Kim Russell, who is the Executive Director for the Arizona Advisory Council on Indian Healthcare. We have Samantha Sabo, who is Associate Professor in Health Services for the NAU Center for Health Equity Research. And we have Luisa O'Mara, who is a research assistant at the NAU Center for Health Equity Research. Next slide, please. The goals for today's webinar is we're going to be introducing the purpose of the CHR Workforce Assessment Project. We will be reviewing major findings of part of the Phase 1. We'll present preliminary results of Phase 2. We're going to discuss next steps and a timeline, and of course, we're going to have a Q&A session at the end of this presentation. Next slide, please. And I will hand it off to our first presenter, Kim Russell.
Thank you, Corey. Good morning, everybody. This is Kim Russell with the Arizona Advisory Council on Indian Healthcare. It's good to see everybody in their parts of the world. I hope you all are doing well. I'm really happy to know that you have interest in learning more about the work that we've been working on in collaboration with the Northern Arizona Center for Health Equity Research. Our state agency, the Arizona Advisory Council on Indian Healthcare, has had a long-standing relationship with NAU through Dr. Samantha Sabo. Dr. Sabo, as you'll hear in a little bit, you'll hear about a lot of the work that she's done to really assess the community health representative workforce here in Arizona. All of this work could not be possible if the CHR workforce themselves were not engaged in this project, and if they were not didn't have interest in really learning more about what they do. So we really appreciate the project partners who have come together to assess the workforce. And like I said, we've had a long-standing relationship between all three partners through NAU Advisory Council, and then of course the 19 tribes in Arizona that have their own CHR program. In addition, we've also engaged the urban programs who also have CHR programs. So it's just a really great collaboration of various entities that have come together to produce this presentation for you this morning. Next slide, please. So I'm going to make an assumption that most of you know what CHRs are, community health representatives, but I wanted to just touch a little bit upon this very unique and distinct workforce. First of all, CHRs, we know that they have a relationship and trust building to identify specific needs of their clients. You'll see the graph on the right here and how the CHRs really connect with all the various programs and resources and social determinants of health so that they can really provide connections for their clients with those various resources. In addition, communication, especially continuity and clarity between the provider and the patient and traditional knowledge and language. So I think that's really key in this particular workforce of the CHRs, and that they have to have some very unique and strong communication skills with the clients that they interact, as well as with the provider that they interact with. So So you'll hear a little bit about how some of them have no multiple languages because that's just what is needed within their community. So communication is a really, really important tool and skill that CHRs have to have. And then I touched upon this a little bit. CHRs, I think just overwhelmingly, the more that we learn about CHRs in this particular workforce, they really focus on social determinants of health. And these are conditions in which people are born, grow, work, live, and age in, including social connectedness, traditional knowledge and spirituality, and the relationship to the environment and the shared history. So again, just kind of looking at the graph to your right there, they focus on the various social determinants of health, whether it be transportation, access to care, food, nutrition, food access. So they really are that liaison between the client and the resources, but also they're a liaison with the healthcare institution. Next slide, please. So this is just a slide of a t-shirt that if a CHR were to wear, it would totally make sense. It just states, community health representatives, we solve problems you didn't know you had in ways you don't understand. I think that it just really speaks to, I guess, the unique nature of the CHR workforce and how valuable you are. And you'll hear a little bit more about what this t-shirt means to us as a CHR workforce. I kind of include myself into that CHR workforce as a honorary CHR just because I really believe in the work that they do and the impact that they can make within our communities. So a little bit about the purpose of our presentation today. You're going to hear from Dr. Sabo and Luisa about the work that they've been doing in collaboration with the Advisory Council and the CHRs in our state. They're going to go over a little bit about, I guess we call it a phase 1 workforce assessment that came out last year. And then they're going to talk a little bit about the phase 2 CHR workforce assessment. The second workforce assessment builds off of phase 1. And you'll see how we just start to learn more about the CHR workforce. And the more questions we ask and we get answered, it just seems to create more questions about the CHR workforce. There's just so much to learn about them. But then also, in learning about the CHR workforce, it also allows us to figure how can we work better with them? How can we really capitalize on this unique CHR workforce? So at this point in time, I will go ahead and hand it over to Dr. Samantha Sabo.
Thanks, Kim. Well, good morning, everyone. Thank you so much for being here. We're so happy that you've joined us today. And that awesome t-shirt really sums up the reason for the need for robust workforce assessments like the one we have the opportunity to present to you all today. So just a little more background, as you all know and are committed to, CHWs and CHRs are part of a global workforce, and CHRs are part of that global workforce of community health workers, which is the umbrella title, job title that is actually recognized by the U.S. Bureau of Labor. And so in this slide, you can kind of see that umbrella job recognized title with the multitude of titles that CHWs and CHRs are often given. Currently, there are approximately 55,000 CHWs employed in the United States, in every state and in almost every territory. Nationally, the CHR workforce, which are tribally employed CHWs, consist of approximately 1,700 CHRs, representing 264 tribes. Of the 22 tribes in Arizona, as Kim mentioned, 19 tribes operate a CHR program and employ approximately 246 CHRs, which is equivalent to approximately 30% of the total CHW workforce in Arizona, which is estimated at about 1,000 CHWs. Since 2015, Community Health Representative Programs of Arizona have come together for annual CHR policy summits and workforce conferences to dialogue and plan for the unique issues and opportunities facing CHR workforce sustainability and advancement. Coalition members understand workforce development and planning as essential to recruit, retain, and sustain a cadre of highly skilled, culturally and linguistically diverse CHRs able to serve the diverse medical, social, cultural, and traditional facets of rural and urban American Indian communities here in Arizona and in the US. We do this by understanding the scientific evidence for CHRs, which you can see on the slide here, which is our conceptual model for conducting a workforce assessment. So we need to understand that scientific base of evidence related to CHRs, including the evaluation and impact studies, as well as how CHRs are integrated and influence care within tribal and non-tribal health systems and programs. And today we'll focus on the CHR workforce itself, and specifically the programmatic infrastructure which supports CHRs. So Kim mentioned phase one. I'm going to take you back in time to 2019, which I don't know how you all feel, but it feels like so long ago since our world has changed. This first CHR workforce assessment was commissioned by the Advisory Council and was the first of its kind and served to lay the foundation for current and future CHR professional development, training ideas, supervision ideas, career advancement and financing of the profession here in Arizona. This report, which is pictured on the screen, with the table of contents, can be located on the Advisory Council and the NAU website, and the link can be posted in the chat section so you all can find it. Phase one of the CHR workforce assessment focused on just that basic documentation of CHR standards of practice, including the training and preparation CHRs hold, the roles, skills, and competencies that they possess and cultivate over their professional and personal life. And we try to compare those existing core competencies, roles, and skills to the national standards set forth by the Indian Health Service, as well as nationally recognized CHW core competencies. And we'll talk about that. So this next slide is some of the data that we found. So in reviewing the scopes of practice for 12 of the 19 CHR programs here in Arizona, we found that community health representative workforce employed through the tribal CHR programs are a highly trained, standardized workforce with a comprehensive scope of practice, which you can see the major headers of the scopes of practice on the left-hand side. Those are the domains of their scope of practice. These scopes of practice, the standards of practice, are outlined by Indian Health Service, but we also discovered that they have been enhanced by tribal CHR programs to better meet the needs of their own communities and situations. And so you can see that new, in parentheses there, community needs assessment is a new core competency, as well as disaster response. And I'm imagining that that disaster response will only increase as we will learn more from Louisa about CHW's impact on COVID-19. According to all 12 participating Arizona CHR programs, scopes of practice and job descriptions identified the CHR workforce core roles and activities, including the IHS standards of practice of health education. You can see at the bottom moving up, case finding and screening, care management and coordination, and patient care and monitoring. Forgot about that click. The next slide that you'll see is we also wanted to look and see the overlap between the national core competencies set forth by the community health worker umbrella title and workforce with CHR specific scopes of practice. And we found that CHRs met and exceeded the national CHW core competencies of providing culturally appropriate health education and information. So on the left-hand side, those are the 10 core competencies that are nationally recognized for CHWs, for conducting outreach, providing direct service and care coordination, case management and systems navigation, and participating in evaluation and research. CHRs are also contribute to the social determinants of health, as Kim mentioned. And this slide here is the vitalist elements of a healthy community. And we use this model to be able to understand data and analyze it. So we use the Vitalist Foundation elements of a healthy community wheel that you saw in the previous slide to analyze CHR scope of practice and learn that upwards of 40% of CHR scopes of practice focus on the social determinant of access to care, and nearly 20% focus on generating, on generating educational opportunities and social and cultural cohesion, among many other determinants of health that you can see here on the pie chart. Focusing in on the social determinant of access to care for 1 minute, CHRs were found to focus on very specific elements of this determinant, including care coordination and management, among many other roles that are evidenced to strengthen the healthcare system overall. And you can see some of those quotes that Louisa will really get into, that CHR managers are able to really talk about how this impact occurs. So now I'd like to shift us to phase 2 of the workforce assessment, which Louisa will present. Phase 2 takes the next step and engages CHR program managers in conversations about CHR program infrastructure, financing, integration with programs and health systems, and the opportunities for process and outcomes evaluation. Most importantly, we talk to managers about the innovative ways CHRs are addressing COVID-19. Now, these can all be a separate presentation, and we're only highlighting our big highlights of these rich conversations that we were able to have with managers and directors, with really the hope to make future presentations on each of these topics in more depth later. Finally, given this is a project driven by members of the CHR Coalition, which has been in existence for almost 5 years now, which represents CHRs, CHR programs, and other American Indian health policy leaders among university partners, we developed the interview questions in collaboration, and we'll present the results, preliminary results, with the conversations that we were able to have with 7 CHR program directors, with a range of experience leading their own program, as you can see there. Conversations occurred over Zoom because we know we can't, because of COVID. And so we had Zoom conversations which were creative and fun, and we made it work. They were recorded and transcribed and analyzed using a qualitative analytics software called Atlas by some of us here at NAU. And this is just preliminary, and so we do preliminary analysis, and then we'll go back to the coalition and interpret those data with our partners. So now I'd like to turn it over to Louisa, who will present the preliminary findings for these interviews.
Okay, thank you, Sam. Can you hear me?
Yep.
Okay, great. So as Sam said, we interviewed program managers at 6 different programs. We were able to speak with 7 managers, and the programs we interviewed really represent a wide range of CHR programs in the state, ranging in size from very small to very large, and operating in both rural and urban environments. Now, we found that we were interested in how caseload was determined for CHRs, and we found that there may be several different factors that managers take into consideration. So geography is one consideration, as is the distribution of disease in the service area. Some also have a minimum number of clients that each CHR has in their caseload. And lastly, they may consider CHR experience or training. So program managers generally said that they try to make sure that all CHRs receive equal training and training opportunities on the job. However, some CHRs come into the position with previous certification, such as a licensed practical nurse or certified nursing assistant, and that may affect which clients are assigned to them. We also found that there may be different categories or levels of CHRs in a program. So we found entry-level CHRs as well as senior-level CHRs, who often have more experience and training and tend to handle more home visits, case management, and community education. some programs have CHRs who are also tribal registered nurses. And one program we spoke to has a number of CHRs who are trained to specialize in either tuberculosis or STDs. Next slide. We found that CHR programs partner with many other tribal programs. So the ones you see here are just those that were most frequently mentioned in our interviews. And as you can see, they fall across the spectrum of community health, from behavioral health to chronic disease prevention and management, maternal and child health, and environmental health. CHRs are actively involved in service coordination for their clients, which brings them into contact with many community partners, sometimes referring clients for service and also providing a number of services to these partners. So CHRs often receive referrals from partners to do things like conduct home visits or welfare checks, especially with hard to reach clients, provide health education on a particular topic, conduct home safety assessments. And another service we found that CHRs provide is the coordination of physical activities for events led by other programs or departments. For instance, organizing a run for heart health. Next slide. CHR program managers talked about the evolving nature of their programs as they grow and make changes to meet the needs of their clients and communities. They described how they are looking to provide trainings for their CHRs in areas such as resource navigation and digital storytelling, as well as providing the CHRs with opportunities to earn additional certification as community dental health coordinators, licensed practical nurses, LPNs, or community health aides. And on the programmatic level, managers discussed their desire to increase collaboration with health system partners and to increase client contact by conducting more home visits. Next slide. We also found that CHRs are involved in a number of special programs and projects that are outside of the usual scope of work, touching on a wide range of community health issues, such as maternal and child health, chronic disease prevention, and advocacy. And several CHR programs also have partnerships with universities where they are working with researchers to investigate health issues in their communities. Next slide. So partners were interested in finding out more about how CHR programs are funded. So first of all, just to be clear, every CHR program receives a certain amount of Indian Health Service or IHS funding, and this is their standard funding line. We found that only a couple of programs we interviewed considered the IHS budget line for CHRs to be sufficient. You can see this described in the quote here from one CHR manager who is only able to cover half his program through standard IHS funding. Most CHR programs that we spoke with employ a combination of funding sources in order to sustain their programs. So the scenarios we found were: 1, relying on IHS funds only; 2, using IHS funds in addition to third-party billing for billable health services, such as non-emergency medical transportation; 3, combining IHS funds with matching funds from their tribal general fund and or tribal program-specific general funds. For example, the tribal health department may share budget with the CHR program. And then 4th, CHR programs may seek out research and practice grants to supplement IHS funds. Another way that managers described being able to fund certain CHR positions was to split a position with another program. For example, a CHR program may share a CHR position with the special diabetes program. One CHR manager also explained that they were able to make requests for small amounts of money from tribal gaming funds to cover special supplies. Next slide. The next area we looked at was program evaluation, and we asked CHR managers how they currently track and measure the different components of their program to know what is working or not. Now, most programs use what is called the RPMS system, which is a data tracking system that was designed for tracking CHR activity. And they use that to produce reports that describe how their CHRs spend their time and how many clients they see. And then we found that 2 programs have access to client electronic health records, EHRs, and through those they're also able to produce similar reports. And 1 program administers an annual client satisfaction survey. So aside from that basic data that is included in the RPMS and electronic health record reports, they also describe some positive evaluation measures they've encountered, which include receiving positive feedback from clients and partners, and observing changes in client A1C through a diabetes registry in 1 instance. Next slide. So in exploring the topic of evaluation, we found that CHR managers reported a number of barriers to conducting effective program evaluation. These included not having access to data reporting systems, feeling that RPMS was a poor data tracking system, not being aware of any appropriate evaluation tool to use, and lacking the knowledge and training needed to conduct effective evaluation. So looking at the quote that I have up here, this is from 1 CHR director who described their difficulty in evaluating their program, saying that they felt that one of the greatest impacts CHRs had on clients was providing them with hope as they navigated the difficult health system, and not knowing how you could really measure that impact. CHR managers expressed an interest in conducting better evaluation. Many were interested in successfully measuring program outcomes and impacts, in identifying program weaknesses and strengths, and in finding an appropriate and effective evaluation tool to use. Next slide. We asked CHR managers and directors to describe what they saw as the value that CHRs provide to health systems. And they described many ways in which CHRs are and could be of value, including serving as an essential link and intermediary between patients and systems. So as you can see in these quotes, CHR managers describe CHRs as being critical to healthcare delivery, as the backbone of healthcare on the reservation, and as the connection and binding component between the community and the healthcare providers. Next slide. So the question is, how are CHRs integrated into the health system? We found that CHR integration really varies from program to program. In most cases, CHRs do work closely with Indian Health Service public health nurses and meet or communicate regularly with IHS staff to discuss case management. Programs that have access to electronic health records and can enter notes and review patient notes and charts are provided with a much higher level of integration of CHRs within the health system. But at the other end of the spectrum are programs that feel underutilized and left out of the loop of patient care for reasons I will discuss more in the next slide. CHR roles, go back, please. CHR roles related to health systems mainly revolve around the coordination of service delivery, making and receiving referrals, providing transportation to health services, contacting hard to reach clients to deliver messages, medications, or do welfare checks. And CHRs also often accompany patients to appointments and provide interpretation if necessary, which providers strongly rely on. And providers also look to CHRs to provide insight into patient needs and their situations. So the quote we have up here is from 1 CHR program director, and it really represents the ideal scenario, one in which the CHR program feels valued and highly integrated into the healthcare delivery system. All right, next slide. So I mentioned that a number of programs feel or experience a lack of formal integration of their CHRs into the healthcare team. So the main issues that CHR managers discussed around challenges were experiencing significant gaps in the communication and referral processes, and encountering challenges related to Indian Health Service staff, which frequently turns over, particularly doctors, resulting in staff members that may not be familiar with and do not understand the CHR program and its capabilities. Additionally, most CHR programs do not have access to electronic health records or patient records in general, so doctors are often unaware of what CHRs are doing for their patients or what data CHRs have collected on their patients. For example, a CHR might have months worth of blood pressure readings on a patient and that person's cardiologist never sees. One issue that was discussed that sort of bridges the gap between challenges and opportunities for CHR integration is that CHRs are seen as the quote unquote safety net for the health system, regularly being called in to solve difficult problems, though generally after the fact, instead of being brought in at the beginning of service delivery. So this position, while challenging, could be a point of leverage for programs in building a better relationship with providers. And then CHR managers also discussed opportunities to improve CHR integration. First is that Indian Health Service leadership should require new staff to take part in an orientation to familiarize themselves with tribal programs. Second, for CHR managers to advocate for their programs in order to build relationships with Indian Health Service leadership. And finally, to work to formalize the CHR program's relationship with Indian Health Service, particularly around the communication and referral processes, so that these can survive staff turnover. Next slide. So as we mentioned, partners felt that it was really important to ask CHR managers about the CHR response to COVID-19 as part of this workforce assessment. We added it at the end, realizing how important it was, seeing that the way in which many Native communities were being disproportionately affected by the pandemic. So we asked CHR managers about CHR activities now in response and what they saw as a potential impact on their program. Next slide. What we found was that CHRs in the programs we spoke with have been highly engaged in the pandemic response efforts. It's important to note that in spite of all the barriers to working right now, these CHR programs have all continued to provide essential services to their clients. CHRs have been part of the frontline emergency response teams in their communities. CHRs have been creating and distributing necessary information, sometimes in the form of newsletters, like the excellent one you saw from Hopi CHR in the previous slide. These newsletters might be around COVID prevention, detection, and testing. And then CHR programs are also distributing necessary supplies, such as masks. One CHR program actually made and delivered kits to every tribal member on the reservation that contained gloves, hand sanitizer, masks, thermometers, and educational information. CHRs have also been critical to the delivery of much needed food boxes, water, firewood, and even medication. CHRs have been conducting regular outreach to clients. In one program, CHRs conduct welfare checks via telephone with over 100 clients each week. And another CHR program has established a COVID-19 hotline that is staffed 24/7 by CHRs and community health nurses. CHRs have also been recruited to assist with case management of COVID-positive patients and to assist with testing and contact tracing programs. Now, in terms of future impacts, many program directors expressed uncertainty of how they would be able to safely conduct home visits, but while at the same time, they really emphasize the importance of maintaining and even expanding home health contacts with clients, and which is really a core part of the CHR program. And now I will turn it back to Sam for our summary and next steps.
Thanks, Louisa. So you all know this is we've been working on this very diligently for about 2 months now. And so we're just at the point of being able to work through all of this incredible information. And we're so grateful to be able to present the highlights, the big picture to you all. And we look forward to writing up the the report, which will go into much more detail. So our next steps really involve that process of conducting the remaining interviews. Several of the CHR programs have been, as Louisa just presented, incredibly busy innovating around COVID-19 and how best to serve community members and clients. And so we'd like to go back to those CHR program directors who have been instrumental and are really leading incident command teams and weren't able to talk to us at this time. We want to make sure that we can circle back around to conduct the remaining interviews with CHR programs. We'd like to complete the full analysis, as we mentioned. We really value in the way that the Advisory Council and NAU have always worked collectively with the CHR Coalition is that we share the draft report back to the partners for interpretation and meaning making to make sure that we're getting it right, that we're interpreting things right, and that we can make better recommendations as a group. So we'll find, and then once we do that, we'll finalize the CHR Workforce Assessment Phase 2 and try to get it out there to all you all. We'll continue to present to CHR programs and broader audiences as we think this information is fundamental, not especially for the health system side and the programmatic side. I think CHR programs can tell their own story very well, and we just want to make sure that that story gets told to the right people and those decision makers that that could benefit from hearing it. And then we want to use the results from use results obviously for strategic planning. The CHR Coalition meets monthly and has robust planning and strategizing efforts that they include both locally as well as in the annual policy summit and conference. So we always try to take these data back and use it for good. I think our last slide here before I turn it back over to Corey for Q&A is, this is a word cloud. We asked CHR managers what the greatest value of CHRs are. And I just wanted to sit on this for a minute so you can kind of see some of the feelings and value that CHR managers see in this incredible workforce. And I think some of the words, the feelings or the values that that pop out to me are really around backbone, and I love thinking about traditional knowledge and spirit and hope. Obviously, liaison and advocate is ringing true, but those are some of the positive feelings that CHR programs express about CHRs. So now I think I turn it back over to Corey, who's going to help you understand how to have our discussion session.
Okay, folks. So there are two ways to participate in the Q&A session. You can click on the chat and submit a question. Your chat feature is circled right there, and we'll be able to click the participant. So you can also use the feature to raise your hand, and you can ask your question as well. I don't see any questions in the chat box, and there are no hands that have been shown up. Maybe we'll give it a few minutes for folks to think about their questions. Oh, so there's a question in the chat box. It says, how much involvement is there among tribes or tribal entities in southern Arizona? And that is from Evelyn. Thank you for your question. Sam, Louisa, or Kim want to take that question?
Yeah, so in regards to the assessment, I'll go ahead and start out, Sam and Lisa, but in regards to the assessment, we do work with all the tribes in Arizona, and so there was a pretty much a formal ask from the tribes in Arizona to participate in the assessment, and that's where I think, was it 6 tribes were willing to be a part of the assessment. You'll notice that throughout the assessment, we didn't divulge any particular tribal name, and we will continue to do that. But if there's a tribe in the southern area of the state, they can and who hasn't participated in the assessment, we would be happy to connect them with Sam and Louisa so that they could participate in the assessment. But I think Sam and Louisa could probably give a more general idea of what regions of the state in terms of the tribal programs that participated.
I think that's a fair statement, Kim. Yep. And regarding tribal participation from the southern part of the state, yes, all 19 tribes are participating in the coalition, which is a great thing. So, which has monthly meetings. So, I think Amanda has a question.
So this question is from Amanda. Just a quick question about the number of tribes with CHR programs in Arizona. Are there any particular reasons why 3 of the 22 do not have programs?
I can take that question, Sam, Lisa. I think it really depends on the size of the tribe. We know that Zuni tribe, they have lands here in Arizona, but not necessarily people who live here. But I'm pretty sure they have a CHR program in the New Mexico part of the Zuni tribe. So they have a program there that is just not here in Arizona. And then for the 2 other tribes that don't have a CHR program, I think they're just not big enough to have one. And I think some of the tribal nations themselves are still trying to build out their health departments. So right now they don't have the capacity to bring on a CHR program. But in the future, I think they probably will. But we also have to keep in mind that the initial funding for many of these CHR programs, although it doesn't have to be the only funding for CHR programs, is through the Indian Health Service. So we got to make sure that there's enough money within the Indian Health Service CHR line item moving forward so that the programs can continue to exist. But for the other tribes that don't have CHR programs, I think there could be other ways that they could start their CHR program should they desire to do so. But that's just from our understanding of working with the tribes here in Arizona, why some of them may not have a CHR program. But majority of the tribes in Arizona do, at least here in Arizona.
Okay, this next question is from Yanitza. Thank you, Amanda, for your question. Do we know if any other states or region in the country have gathered or advocated for their CHR programs like Arizona?
This is Kim again, and hi, Yanitza. Working with the CHRs here in Arizona, it's just, we've done a phenomenal job in really bringing them together, and they come together all on their own. There isn't any line item or grant that helps them come together. So it's really something that they've done because they feel that it's important to come together and network. In regards to other states, I've heard a little bit about maybe some coalition building in Oklahoma. I think there was maybe a conference they had put on at one point. And then what we've also noticed is that when we hold our yearly summits, we get CHRs coming to our yearly summits because they don't have that type of summit in their state. So we've had CHRs come in from all the way up north in Minnesota to New Mexico to California, just all over the nation, what just kind of tells me that there's a need to really bring this workforce together, not only within our state, but nationally. There's a desire to bring them together. And I think at one point in time, in the past, they did have national CHR conferences, but if there's anybody on the call with us today, the webinar today, who the CHR, they could probably also answer that question. But that's my knowledge in terms of working with the CHRs for the past 5 years. But I think it is needed, to bring these CHR programs together so that they could, do assessments like we're doing and really be able to advocate as a workforce.
Thank you. We have a question from Julia. What is the ultimate goal and long-term use for this vital information? That's a good question. They're all good questions.
Mm-hmm.
So I'll go ahead and take that too. Sam and Louisa, please feel to jump in, and if anybody would like to also respond to Julia in the chat, please feel free to do so. I know that there are some awesome CHR directors on the call. So one thing that we've been talking about in our monthly meetings with the CHR program managers that we've been having for almost, I think, about 3 years now, consistently, has been kind of revolving around 3 issues. One issue that we always bring up in a lot of our conversations is the desire to use this information to maybe help us create various policies and create the advocacy around reimbursing this workforce for the services that they provide. And because a lot of the clients that CHRs reach out to and provide their services to are going to be clients who are on Medicaid, that's probably one of our focus areas that we would like for to start to have those conversations around, is how do we work with our Medicaid agency so that we can create some sort of reimbursement mechanism for them. As you know, most providers are reimbursed for services that they provide, whereas with our CHR workforce, that's not happening right now. And it's really important that we do that so that we can sustain this particular workforce. We've done a little bit of research, and Sam, you might want to chime in on this, but in regards to the various states in the nation who reimburse for the community health worker workforce, which is inclusive of CHRs, it's very rare to see that happening. I think there might be 1 or 2 states that tried to do that and maybe weren't as successful. So I think there's an opportunity here in Arizona to kind of be one of the leaders across the nation to reimburse this particular workforce and better integrate them into medical teams. So that's just one way, Julia, we could actually use this information long term. And Sam or Louisa, do you have anything to add to that?
Kim, I think you're right on. And I think there was a slide earlier that really told that story, that those 4 quotes, this idea of CHWs and CHRs as the backbone and the glue. And we want that recognized. And I think the more CHRs and CHR programs tell their story and truly articulate the impact that they have on community members and systems, the better position they are in to be able to strengthen their workforce. And so I think Kim nailed it on the head. We want a strong, robust CHR workforce in the state of Arizona and throughout the country, because we know that the scientific evidence is overwhelming on their ability to change the course of individual, lives, both on a social determinant side as well as the health outcome side. So I think that's why we do the work we do, to try to better tell that story and use systematic methods to be able to tell that story. Yeah.
Yeah, so I think, I mentioned really briefly, Julia, the need to really integrate CHRs into that medical team. I think some of this information can assist in that movement to do so. As as was mentioned earlier, there's only a few CHR programs that are at least trying to be really integrated within that medical team. I think we also heard earlier today, this morning, that there are actually some providers that don't even know what a CHR is, and so if they don't know what they are, then how do they utilize them? In addition, I think some of this information can help, and it has already helped in terms of the CHW voluntary certification that the state is embarking upon. I think it's important for this type of assessment to kind of create policy, especially the CHW voluntary certification, which Arizona is conducting. And then also, which is really good about that is through the advocacy, and because the CHR programs are an organized group, we were able to ensure that there were at least 2 CHR tribal directors on that advisory committee to create that CHW voluntary certification in Arizona. And then the only other thing too I wanted to mention, Julia, is that this also helps us at the CHR workforce to really identify training opportunities and really that professional development of that particular workforce. If you know the CHR workforce, and the more that we learn about it, they are just a very highly trained workforce. They're always being trained in different facets of what their community needs them to know. So I think some of this information can help us do that. We recognize that there is a need for training for the workforce, and I think for the most part the tribes find those training opportunities as needed. But those are just a few areas I think we concentrate on, and I think that this information through the assessment can help us build upon.
Thank you. The next question is from Loretta Haven. This question is for CHR programs. How many CHR programs have taken any type of contact tracing training in response to COVID-19 to support contact efforts for contact tracing?
I wonder if they could use the yes function.
And then, Corey, we can always ask that question to the CHR directors through an email, since we connect with them through email as well. We could do that.
I'll take note of that question. All right. The next question is from Evelyn. How close are you in conducting the cost-benefit analysis and return on investment studies?
I can take that if you want. Thank you, Evelyn. That's an important question. So we aren't close here. There's probably a growing group of studies on the larger CHW workforce in terms of return on investment that have been done. And so we're able to understand more from that side of things, and then try to extrapolate and figure out what that would look like for CHRs. But as the CHR programs mentioned, there hasn't been a robust evaluation, an impact evaluation, or an outcomes evaluation of the program. So we would need to do that first, and then we could use some of the knowledge that's been built in the CHW community to attach value to those outcomes. But that's what we're working towards right now. We collectively wrote a robust evaluation plan through the Patient-Centered Outcomes Research Institute, which is called PROCORI. And although we reviewed really well, we will probably need to resubmit that and try again to be able to look at the electronic health records. So being able to use some of the patient outcomes that are gathered in the health records to be able to attach how CHRs are impacting that. But if anyone wants to collaborate, let us know.
Perfect, thank you. Our next question is from Julia. If CHR programs are funded by IHS, why wouldn't that give them access to RPMS to better coordinate care?
I can
Well, we
take
could-
that if you want.
Oh, good, thank you. Go ahead,
Yeah.
Sam.
And Loretta is on the call too, who's the CHR, and I think Jeanette as well. So we have experts in this area who are the CHR PHN consultants for Navajo and Phoenix area. So I don't want to speak out of turn. I think I'll just say that RPMS wasn't necessarily set up for that. RPMS is really a process. It's a tracking system for looking at counts, how many people served in what areas and what types of people are served. But it wasn't built to do that type of evaluation of the program. So it's not connected to the electronic health record. There is no communication between RPMS and EHR. At this point in time, that might be in the works on the IHS side, but that's kind of where that is. So it wasn't built for it, and it just needs a makeover maybe. But I don't know if Jeanette or if Jeanette or Loretta, you want to say anything, we can unmute you.
I'll unmute Loretta, or can I? Actually, you might have to do it, Sam.
Okay. Where are you at, Loretta?
Can you guys hear me?
Yes.
Okay,
Yeah,
hi, this is Loretta. Hello, everybody. Thank you guys for putting this webinar on, and I'm glad I caught it. I'm just, I put in response to Julia's question that I've been advocating on my end from the IHS Phoenix area, and this is an ongoing effort, especially now with our COVID response. This is even going to be more important that, we really need to get those CHR programs on there. So I know there has been a multitude of trainings that have been sent out, and when I send those emails out to the CHR directors, rarely do I get a response back from anybody that says they've taken the training or, that they're interested in it. So, I just like to take this platform to say, really need communication from the CHR programs to come back to me at the Phoenix area so that I know what's happening. So, I do hear from time to time from several programs, but that doesn't entail, a majority of the programs. So I've been out in the field in this response for over a month, so I haven't been very active with ongoing things, as my everything has shifted, and we all know that this is our priority right now, and I just wanted to put that out there. And so right now from the Phoenix area level, what we're looking at is really expanding this the CHR programs to assist in contact tracing with other teams, because as I mentioned, we had a headquarters call before this meeting, and they're really looking at rolling out how can we get the CHRs to really make an impact with contact tracing, and like we've heard before, with working with the PHN programs and really just seeing what they can do. I mean, it can be a difference, it can be on a level of just making a phone call, checking up on patients out there virtually, so just really looking at all of that. And so that's been one of my tasks that I've been really trying to look at. And this afternoon, I'll be having a meeting with the PHN, with the PHNs in the Phoenix area, because we know that this is, these cases are rising and they're hitting every part of the state. So we really need everybody's involvement, and the more we can all jump on board and, move forward with that, I think the better. Like I said, in getting that RPMS access and having the CHR programs really start documenting will really, really enhance what we're doing in response to this. So I just wanted to say that and see if anybody had any other questions. I know that there was those John Hopkins webinars. I don't know if they were planning on having any more, or maybe I don't know what the update is from that too. So I'm not sure if anybody has any information in regards to that.
Thank you, Loretta. We have, it looks like our last question, if there's no more after this, from Jeanette. For the Navajo Nation, or maybe this is just a more than a statement rather than a question. For the Navajo Nation, the CHRs do not have access to the AHR system right now, and this continues to be a challenge.
They do have.
Oh, do have, sorry.
Yeah, they do.
Access. Is this Jeanette?
Hi, this is Jeanette. Can you hear me?
Yes, we can. Did you want to elaborate a little bit more on what you stated?
Right. This is it's interesting since I've been here. Initially, when I came, the CHRs did not have access to EHR in the system. And then gradually over time, with some protests, they were allowed to access it. And a lot of times the question came up, who's going to provide their computer security, education, training each year that's required. And basically what they end up doing was just kind of being put in with, since the rest of the IHS staff have to also take the same courses and they're all online. And so that's gone along for a while, but recently my understanding, and Loretta, you could help me with this, IHS as a whole has put out some type of a regulation or some type of ruling saying that due to the cost of access for the tribe staff to RPMS and through their PIV card, that they will no longer support that. On the other hand, I understand CHRs who already now have a D1 account will be able to continue access into EHR. I'm still making efforts to verify among the CHRs who have D1 accounts, who don't, because the PIV cards that they have now, and some of them do have it, will expire in the middle of January. And so they're concerned how much access. And I think each agency across Navajo, much like the IHS system, some people have more access to what are the HRs than others, depending on how the assignment goes. It'll be interesting how this all really comes to play, I believe, mid-July. I'm encouraging the CHRs now go in and test their D1 account if they still remember their account access codes. But there's a changeover, at least even on Navajo. We have a PHN. We have one program, Navajo, in Kayenta, that's tribally managed. With one PHN out there, and she was majorly concerned about it, and we certainly are majorly concerned because she does need, even though she's a tribal member, or tribal employee, she does need access to the system. And so there's some ongoing support on hers that somehow having her continue to at least have the PIV card, because the PIV card would give her more access to the information in RPMS along with EHR. So it's always been kind of a challenge. I'm sure that some other IHS areas, their CHRs do not have access to EHR. The other part of that is once the CHRs do submit the information into the EHR, the other challenge is who's going to data input that. So then the CHRs get credit for the visits that they're doing. That's the other end of the spectrum, is once the PCC is completed, who's actually going to data entry that. At one point, I know, a nation had hired data inputters, and then that kind of, I don't know what happened, it kind of went on the wayside. So it's a challenge. For sure.
I know we have, thank you, Jeanette. I know we have Michelle Archuleta on the phone, who is the CHR consultant for Indian Health Service, and she'd like to comment. I am having trouble unmuting her.
Hi, Samantha, can you hear me?
Yep.
Okay, great. Yes, thank you so much for the opportunity. I was invited by Loretta Haven, and so I just want to say I'm so appreciative of the information, the work that the Arizona CHR coalition, I hope I'm saying it right, has done with this assessment. I think it's just so important. It's actually a best practice from what I'm seeing that our other area programs could benefit from. But yes, I did want to say I just started in February with the headquarters Indian Health Service. I actually came from the Bemidji area as the Bemidji area health promotion consultant. And so I have been working with Loretta and Jeanette. They are a part of a national team of CHR consultants, and we are trying to figure out this one piece around RPMS access for tribal programs. And Loretta is spot on when she says that it's really important for her tribal stakeholders to have that access. Unfortunately, one of the drawbacks for that is when tribes actually take their program shares and they move into a, it's called COTS, a consumer off-the-shelf electronic health record, you know, that actually creates this sort of reporting gap of data in terms of the CHR exports back up to headquarters. And so we are working behind the scenes to hopefully close that and bridge that gap where the reporting can be actually more seamless. You know, you won't notice it, but it just happened. But I don't know, I just wanted to just say I'm so appreciative of everyone, what you're doing in the state of Arizona. You really are doing fabulous work. Any way I can be a part, I'm happy to be that advocate on behalf of the work locally and regionally. So that's what I really wanted to say. So thank you very much.
Thank you, Michelle. We have another question. Oh, it looks like a statement from Marianne. Salt River CHRs also have access to EHRs. Sheena, I understand AHS is considering the purchase of a new EHR system. Does anyone know of the CHR functions will be included for the new system?
Does Michelle or Loretta or Jeanette want to take that?
You know, this is Loretta. I'll just say they have been talking about that for a while, but I think that's still a couple years out. So right now, in regards to, you know, the RPMS, that's where the CHRs have access into that. So, you know, that would be something that, you know, I think, you know, us as consultants, in addition to headquarters, would be something to keep in mind too as well. So I don't know if anybody else has any updates. I may have not have heard that, but you know, that's...
Yeah, and this is Michelle. I will jump in there. Loretta's right too about that. The IHS is looking broadly to move and transition similar to what the VA has done. They're moving away from that RPMS tracking system. You're right, it wasn't meant to be an EHR, but it became one. And so we are, I don't know if they have identified anything in particular at the moment, but it will be a transition. But then the other part about that is, depending on maybe the state of Arizona, all the tribes, you know, they probably won't use the same EHR system. Some will be very different. I mean, there's many EHR systems out there. And so I would just say, if you're a program manager and you have that opportunity to be a part of those conversations of introducing a new EHR, and they want to know, well, what do we need to have as important CHR functions? That's where you're going to advocate and hopefully work with the developer of that EHR system that they're bringing in to make sure that your workload is captured and transmitted. So you are going to play a real important role with that.
Thank you. It is 11:10. Would anybody like to share, have another question or share what they're doing for the CHR directors? Oh wait, I'm sorry. I see a question from Evelyn. Will tribes be invited to provide input on the IHS EHR?
Absolutely. This is Michelle from headquarters. I would say absolutely.
Okay, thank you. And we have a question from Fernando. Can CHRs work with IHS to build, develop, and design a new system for collecting data and reporting?
Oh, absolutely. and in fact, I would say, Fernando, work with your this group. Maybe this is just a good way for me to kind of touch base with this group, and I can help take some of that information to help us situate it with our national OIT folks. But yes, I mean, and as you all know, we just have lots of layers, but I think it can work. Yes.
This is Loretta, and I'll just say a comment. I'm so glad that that Michelle, that you came on the phone, and also to Jeanette. You know, I think, you know, as we're moving forward with this, you know, this is really important, and I'm really glad that I was able to catch this and stay on, because this is exactly what we need to move forward. And really hearing, you know, everybody's input from Dr. Sable, from Kim, you know, from Corey, you know, from everybody, Bo, you know, all the others, you know, thank you for being on this call. And, you know, this is what we really need to really move forward again, because, you know, this is important information. So thank you.
Yes, Loretta, can I jump into that CHR Data Mart? That is really a gold mine. And I don't know if many of you know that, but we'll work with this organization. I mean, that can be a place to also move that data. You can extract that data. You will be able to use it for program development, grant development. So I want to just put a plug in for that CHR Data Mart. We actually are doing an overhaul on that. So more to come on that.
Yes, thank you.
Okay. If there are no more questions, this concludes. I'm going to hand it back over to Kim to close out. Thank you, everyone.
Thank you, Corey. You know, thank you, everybody, for being a part of our webinar this morning. As you heard from our presenters, there's just so much information and so much to learn about the CHR workforce. This is a really unique workforce, a very impactful workforce. If you didn't know this, but the CHR workforce, I believe, was the first type of CHW model in our nation, and that the CHR workforce has been around for over 50 plus years, 50 years. So I think we're at a point in time that we can figure out how to fully integrate this wonderful workforce into the greater medical teams. Not only medical teams, but you heard as well how they're integrated in the community and how they really connect to, you know, social determinants of health. They are such a valuable workforce. So again, thank you for everybody joining us. I really appreciate the Indian Health Service staff that was able to join us. I know you all are very busy. Corey, Sam just put up a slide where you can find our information. If you have any questions beyond this webinar, please don't hesitate to reach out to myself or Corey, Dr. Sabo, or Louisa. And I know that you probably interact in some way, shape, or form with your CHR program directors. Don't hesitate to reach out to them as well and get to know their programs and the awesome things that they're doing. You'll also notice here on this page here that you'll see our website. So the report will be posted on both of our websites. Just know that you can visit our websites and find not only the report that's coming out from the phase 2, but also the report that we talked about for the phase 1. They complement one another. So with that, you all have a good rest of your day, and please be safe. Thank you for joining us. Bye, everybody.